Maybe I actually kind of just mentioned that one, so I don't need to ask it that. All right, so here's a true or false question. All right, so tell me, is this true or is this false? This is a true or false question regarding the use of controlled ventilation. True or false? You can use larger IE ratios, and controlled ventilation may improve oxygenation. You can use larger IE ratios, and it may improve oxygenation. True or false?
Yes, with ARDS patients.
Sorry? Are you saying true or false?
Like, you mean true for both of them?
Can you repeat the question? I'm sorry.
Yeah.
Sure. All right, so it's just one statement, but I want you to tell me if my entire statement is true or false regarding the use of controlled ventilation. So with controlled ventilation, you can use larger IE ratios, and it may improve oxygenation. So take it piecemeal. If you're using controlled ventilation, can you use a larger IE ratio than you normally do?
No.
I can't go 1 to 3 or 1 to 4, 1 to 5. I can't do that if I need to.
Yes.
Yeah, I can do that.
You can.
Yeah, because I'm controlling.
You're controlling
ventilation. So if I have a COPD or who needs a 1 to 3 ratio, IE ratio, I can do that. Because remember, I showed you guys how you can do that. You can change that IE ratio target. So you can do that. All right. So now let's go to the last part of that. I said it may improve oxygenation. So if I'm using controlled ventilation, can it improve oxygenation?
Yes.
Say yes, please say yes.
Yes.
So that is true. So that is true regarding controlled ventilation, because I'm controlling everything. I'm even controlling the O2. Also, when we talk about CO2, that helps with your oxygenation as well. So yes, all of that can lead to improved oxygenation. All right, so true or false with this next question. Same thing regarding controlled ventilation. It requires the use of paralytic agents in spontaneously breathing patients. It requires the use of paralytic agents in spontaneously breathing patients.
I say true.
Somebody said true.
Yeah.
Who was that? Was that you, Taylor?
No, it was me, Flo.
So yes, that is true. That is true. It does need, if you're controlling the ventilation, you do have to paralyze that patient. Right, correct. You do, because you're making them breathe differently from how they want to breathe. So you have to paralyze them. So that is correct. That's true. All right. True or false? The therapist has little control of the needed respiratory flow and pressure. The therapist has little control of the needed inspiratory flow and pressure.
False.
That's false.
I hear 2 false.
False.
False. What about the rest of you?
False.
False.
Yeah. That's definitely false. The therapist has all the control of everything, including the flow and the pressure. So that one's false. All right, so here's another true or false. Still with controlled ventilation, this may allow the muscles of breathing to rest. Controlled ventilation may allow the muscles of breathing to rest.
Yeah. True.
Okay, that is true. Yes, so that is also true. Correct. All right. Okay, so here's a true or false regarding pressure-supported ventilation. Okay, so that was control ventilation. This is regarding pressure control ventilation. All right. All right. The usual range is between 10 to 15 centimeters of water. The usual range is between 10 to 15 centimeters of water. True or false?
And what is that? What?
Pressure supported ventilation, usual range between 10 to 15. What's that?
Say true.
I hear true.
True.
I hear another true. What about the rest of you?
I say true.
Yeah, I'll say true.
True. Alpha, you're muted, but it looked like you said that's true. 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 Okay. Mallory?
Yes. I said true.
Okay.
Yeah, true.
Yeah, actually, it's usually between 5 and 10. 5 and 10. Oh, gotcha on that one. Okay, I need my sound effects wah, 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 on this one. So yeah, the usual range is between 5 to 10. Now you can go as high as 15, but you're going to start off in the lower ranges when you go up to 5 to 10. I mean, Susan, go up from 5 to 10. Great. Okay. All right. So another question regarding pressure-supported ventilation. Pressure-supported ventilation, it is patient-triggered, pressure-limited, and flow-cycled. So pressure-supported ventilation, it is patient-triggered, pressure limited, and flow cycled. Now I'm hearing some feedback. Are y'all hearing feedback?
Yes.
I'm hearing feedback.
Mhm.
All right. So Nicole, mute yours for a second. Let's see if you can hear it. Yeah, I think that was it. I think that was it. So you're gonna have to just kind of unmute when you want to talk. Remember to unmute. All right. So, true or false? With pressure-supported ventilation, it's patient-triggered, pressure-limited, and flow-cycled.
Yeah, that's true.
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 I hear some truths. Everybody want to go true?
Yes. I say true.
All right.
So, I'm not confident in my true because I'm kind of stuck on the flow.
That might be in pressure control.
It's true. It's in the handout we got. What is it called?
Which one is it?
The one from last term, the chapter 5, selecting the ventilator and mode.
Oh, okay. Then I stick with my true.
Okay.
I know we got it this term too on one of our one of the study guides. We just had it on the test not too long ago.
I don't know if that's helping you, but
Yes. Yeah.
yes, it is true. It is patient triggered, pressure limited, and flow cycled. So,
because it's only supporting the patient's pressure as they breathe. So the patient is triggering the breath. That's how I remember it. So I know that part was right. The patient is triggering the breath. It's only supporting the pressure.
the inspiratory
Yeah.
right there. Right. Absolutely. Yep. And then, of course, it's pressure limited because whatever you set, like if you set 10 of pressure support, then that's where it cuts it off. It
Right.
stops at that 10 centimeters of water. And how does it do that? By flow. So your flow, your sensitivity on there, how does it cycle off? Well, it senses the amount of flow that's coming through the system, and that will stop as well once you reach your pressure amount to end that breath. True or false still with pressure support? It can reduce the work of breathing during IMV, the IMV mode. It can reduce the work of breathing during the IMV mode.
True.
I hear true.
True.
Yes. 2 trues. 3 trues. Okay, correct. It can reduce the work of breathing not only during IMV, but it can reduce the work of breathing, period. That's the whole point of pressure support, to give that extra support during inspiration so the patient doesn't have to suck so hard to start the breath. So it can help reduce the work of breathing imposed by the extra resistance from the ET tube, from your circuit, any artificial airway. It helps to reduce the work of breathing. So that's the whole job of pressure support, is to help reduce that work of breathing. All right, so true or false, it is recommended for the use in most patients in the SIMV mode. It's recommended for use in most patients in the SIMV mode.
False.
All right, I hear a false.
False, I think.
I hear
I think it's
another
false.
false. Okay, 2 falses.
I think false as well.
All right. What about the rest of you?
I say false.
Nicole, I think you're muted.
Oh, I'm gonna go with false as well, because it's SIMV.
Okay. Alfie? False. Everybody said false. Mallory, Taylor, Flo?
False.
False too? That is actually true. Interesting that y'all said false. So if it can reduce the work of IMV, why wouldn't it be recommended?
That's true.
Because SIMV is IMV, right? So if it can reduce the work of breathing, because it kind of almost similar. The question is very similar, but it is recommended for use with SIMV because you have that patient who's breathing spontaneously, who is triggering the vent there, and they will need support to get that breath in, and that often helps them wean with using pressure support. So yes, it is recommended for most patients in SIMV. Gotcha on that one. All right, so if your patient is in assist control, okay, if your patient is in assist control and develops a high vent drive, what results? Patients in assist control, high vent drive results. What acid-base balance results? Let me help you out there. What acid-base balance results?
Alkalosis.
Yes, alkalosis.
Respiratory alkalosis, right. And why? Why would it be a respiratory alkalosis?
Because they're blowing off CO2 with the high respiratory rate.
Okay, so how does that lead to respiratory alkalosis? Give me a specific. Tell me. Pretend I don't know what that means.
Well, the increased respiratory rate, it makes them breathe faster, so they're breathing off their CO2, which then decreases their PaCO2 in their blood gas, which would increase their pH.
Okay, so a pH greater than 7.45 is alkaline, and then a CO2 less than 35 is alkaline. Yes, so that's what I'm looking for, right? Give it all.
I didn't know how specific you were.
I said, tell me, pretend I didn't know anything. That means say it all. Say as much as you possibly can. Air trapping is a major concern with what diagnosis when using assist control?
COPD. COPD.
COPD. Auto.
Somebody said COPD. That is correct. Yes, COPD. Ear trapping is a major concern in patients with COPD, right? If you are, and mainly because, well, you're assisting them, but still it's a control mode. So if you have the setting, the rate wrong, the IE ratio, whichever you have it set by, you could cause their IE ratio to be ineffectual and not give them enough time to exhale. So just kind of be careful, with your patients who are in any control mode. If you have a COPD patient, be careful, watch their IE ratio, watch their flow, make sure they don't trap, and watch their auto peeping, and if they are trapping, fix it. Okay. Okay. This is interesting. All right. So I'm trying to figure out how to reword this one. All right. Here, we'll just do true or false. True or false. This question is for patients in the assist control mode. All right. And these are patients that have a high ventilatory drive. Okay. So if you've got a patient in assist control mode, they've got a high ventilatory drive. True or false? This is a strategy that is used to avoid hyperventilation. Okay, so patient in assist control mode, they have a high ventilatory drive, and this is a strategy, to avoid hyperventilation. Analgesics. True or false? Are analgesics used to avoid hyperventilation?
My gut is telling me false, but that doesn't mean it's right.
I think it's false.
I think it's false. Okay. All right. What about the rest of you? Analgesics. What do analgesics do for you?
Analgesics.
What is an analgesics? An analgesic. What is an analgesic?
Paralytic.
No, it's less.
It's like what do you call that? Not a paralytic.
What'd you say, Drika?
Is it a pain reliever?
Yeah, it helps to relieve pain, helps to numb, some areas. So it depends on which kind of analgesic, but mainly it's for pain and numbing, gives a little numbing effect. So if you have a patient who is hyperventilating and you give them a pain medicine, give them an analgesic, what would result? What are we worried about a lot of times?
With the reduced respiratory drive.
Medications, they suppress this respiratory drive.
So it is a side effect. So it is something that can be used to slow down a patient who is breathing too fast. So if you have a patient who is hyperventilating, we need to relax them a little bit. You can give them pain medication. A lot of times, patients who are hyperventilating is because they're in pain. So one of the things you're going to ask if a patient has a high rate of breathing is, are you in pain? So you're going to ask them if they're in pain, because that can be one of the reasons why they're breathing so fast. So analgesics, yes, that is one of the strategies that we can use to avoid hyperventilation. How about tranquilizers?
Tranquilizers do the same thing?
It's in that same group there. We don't use the word tranquilizers anymore. It sounds like we're kind of trying to put out an elephant or something. But tranquilizers, yes, that's an old school term there. I was like, wow, okay, that's still in the test. So yes. How about switching modes to maybe SIMV?
I don't think it would be SIMV because you're trying to control it. SIMV, you really not controlling? Does it have to be spontaneously breathing?
Are you?
I do not think it's SIMV. Because that's the synchronizing so the machine they'd be synchronizing with high rate. So I'm going no.
Okay. What about the rest of you? SIMV, what do you think?
Let me see. When the machine stop breathing so fast, I mean, you're supposed to be breathing a certain, but it's synchronized, so the machine will slow you down. So I'm saying, yeah.
If you're in the assist control mode?
Oh, no. You're saying, okay, so what is the question again? Because you're saying, what if SIMV? Are we supposed to be using the same medication in SIMV? Is that what you're saying?
The question is, you have a patient who's in assist control mode,
Mm-hmm.
and they've developed a high ventilatory drive.
Mm-hmm.
Okay, so to avoid hyperventilation, there's some things that you can do. One of the strategies we said would be to use analgesics.
Mm-hmm.
You can use tranquilizers or, sedation. So we'll say sedation, tranquilizers, and analgesics. Analgesics more for pain. Tranquilizers would be more for sedation to relax. And then another option was to go to SIMV. Okay, so you're answering the question now: is SIMV a strategy that can be helpful to avoid hyperventilation?
I want to say no.
Okay. Yeah. Everybody's saying no. Mallory?
Yeah, but the word synchronized means you're going to be breathing together. It's not going to have you breathe fast unless you put it that way.
But
are you talking assist control mode or are you talking SIMV?
SIMV, the patient is going to be. The machine's going to breathe the patient's rate. Like the machine's going to synchronize with the patient in my head. So I'm still on the no train.
Okay. Nicole? AJ?
I'm gonna go with no.
Well,
The whole thing is
with the SIMV, I get what Amanda is saying, that the machines, but I mean, would it be something we set? So wouldn't we be like, it still goes back to control. I don't know. It's kind of
control. In assist control, you will provide the rate. You'll provide the tidal volume. And the machine will then allow the patient to trigger a breath. So everything else you're going to control. So you'll control their rate. You'll control the tidal volume, and then allow them to trigger.
Okay, so I think.
Right, we're switching to assist
from assist control point, yes, but you're saying SIM.
But she's saying switching from assist control to SIMV.
Right. So
no.
If you go from assist control to SIMV, now SIMV, you're not controlling their rate. You're not adding controlling.
Well, no, you wouldn't.
You're allowing the patient to trigger every breath, right? So, and then whenever they want to breathe, the machine won't give them an extra breath. It'll breathe along with them, right? So, which one will be more conducive to avoid hyperventilation?
The analgesics.
No.
Control.
Control would be more
Oh, yeah, that's good.
Yeah.
Hey, Morgan, I messaged you. I don't know if you got it or not. I was just letting you know that when I clocked out yesterday, I realized that I didn't clock in for my shift, but and I left out the door without.
I thought you saw that.
Well, I forgot to.
You forgot to read it.
Just tell all the business. Okay. Actually, SIMV is a strategy to try to avoid hyperventilation. So here's the thing. If you're in assist control, right? One of the reasons that you would wean a patient if they can breathe on their own, right? So if they have a high drive, ventilatory drive, that means they can breathe on their own. They're breathing spontaneously, and you don't want to control their breathing. So in assist control, what are you doing? You're letting them trigger, but then you've also added extra breaths. So now you're giving extra breaths along with their assisted breaths. So that can, lead to more blowing off CO2 and then alkalosis. So SIMV is a reason to, you can switch from assist control going down to SIMV because now you're weaning. You're in that weaning mode when a patient can breathe more on their own. So if you have a patient who you're in assist control, every morning, what you're going to do is you're going to try them out you're going to do a spontaneous breathing trial, right? So if they've got a high vent drive, that would be the patient who does well. Okay? So your patient who is in assist control and you switch them over to pressure support or some spontaneous mode like SIMV, where they're going to do well with it because they're breathing on their own. They have a high ventilatory drive. So high ventilatory drive doesn't always mean a bad thing, which I think probably some of you, that's what you were thinking, that it's a bad thing. But it just means that they're breathing more on their own. So with this particular question here, it's just asking about strategies. So SIMV is one of your strategies to prevent hyperventilation. So just make note of that. So don't get frustrated, don't get upset about it. It's just a question. So it is a strategy that can be used to avoid hyperventilation.
I don't like that question. Can we throw that question out?
No, ma'am. Just because you don't like it is not a reason to throw a question out.
Okay, this is the one that's working against the machine because they are trying to breathe on their own.
In assist control?
Yeah, because they're like you said, they're ready to wean. Like they're ready, so they're breathing over the machine. They're trying to get those breaths in, but the machine is so regulated that they're trying to okay, I understand it.
Good. All right, so the question is asking you, what are some strategies to use when you have a patient who's in a control mode and they get that high ventilatory drive? What do you do to avoid hyperventilation? We said analgesics, we said tranquilizers, and we said SIMV. Would you reduce the flow? Would reducing flow be a strategy as well?
No.
No, it's not. No, reducing flow is not a strategy. If you have a high ventilatory drive, what do you need? You need more flow. So flow is something a patient is going to need who has a high ventilatory drive. So no, don't reduce the flow. Wait until they're a little more stable and won't need the flow so much. So no to the reduced inspiratory flow. And if you want to go to Egan, it's in your book. Egan 1124. If you go to Egan 1124, you can find that there. It's in your book. All right, so one more question and then we'll take a break. All right, so this is still on your modes of ventilation, and we're talking about partial ventilatory support. So identify some modes of ventilation that you can consider when you want partial ventilatory support, such as like SIMV. That's considered one. What's another mode that is considered partial ventilatory support?
PAV.
Is that pressure support?
Pressure support is one. And now the flip side of that is volume support. So you got pressure support, volume support. What else? There's like two others that are your adjunct, or the ones that are fairly new. I don't know if you guys remember PAV.
Yeah, PAV, NAVA.
Yes, PAV and NAVA. Those are all partial vent support. All right, questions. And no, we cannot get rid of that other question, sorry.
That's right.
Well, we should all know about now.
Right. Now we're not going to forget it.
You know, well, that's the whole point of the review, but, you know, we can stop if you want. We don't have to do the review. You know, if you're going to be getting frustrated and upset with questions, stop. And we can end it right here and move on to something else. If that's what
No, we're good.
we can do that. All right. Okay. Well, let's stop anyway. We'll take a break. So we'll come back. What time? I've got